pleased to have with us today Dr. John Hammer. He obtained his training in internal medicine and infectious diseases at the University of Colorado and has had subsequent training and certification in both tropical and travel medicine, volunteering along the way on several training assignments in developing countries over the past decade. He's worked at Rose Medical Center for the past 14 years, chairing the Hospital Infection Prevention and Antimicrobial Stewardship Committees for the past 5 years, and is an active member of IDSA and SHE. He also works as an antimicrobial stewardship active member of the CHA Antimicrobial Stewardship Program here. That was a little confusing, I apologize. We are very fortunate that we have the services of Dr. John Hammer in our antimicrobial stewardship work, and so I'll turn it over to him and let him go with it.
Well, thanks a lot, Terry. It's a pleasure to be able to talk with the group today and have this opportunity to discuss the proposed CMS rule change and the Joint Commission changes that are on our horizon and actually are going to be a reality for hospitals across the country very soon. So today we'll look, basically our objectives will be to discuss the need for the purpose of the update as envisioned by CMS. We'll talk about the basic components of the update. This includes patient rights, quality, assessment, performance improvement, which I'll call QAPI, so I don't have to say that mouthful for the whole talk. It discusses nursing services and medical record services, but we're really today going to focus primarily on the infection prevention and control and the stewardship components of the program. And then at the end we'll discuss the Joint Commission stewardship requirements, which will be a part of our reality within the next several months. And hopefully there'll be some time for comment and discussion at the end of the talk. I'll try to move through these, at least the initial slides, fairly quickly. So the overall goals of the proposed changes. CMS believes that it was time to modernize the conditions of participation with hospitals and critical access hospitals around the country. And so the goal of this pretty far-reaching document is to do that. The overall arching goal, of course, is to improve quality of care, and it will support the health and human services and CMS priorities to not only reduce the readmissions, but also reduce hospital-acquired conditions, infections, and reduce inappropriate antibiotic use, and overall strengthen patient protections as well. So the goal again is to revise the conditions of participation, or the COPs, to address not only stewardship issues, which we'll talk about primarily, but also discriminatory behavior leading to barriers in care. There's some minor changes with respect to the outdated use of the term licensed independent practitioners. We'll talk about that quickly. Requirements that don't conform to the current infection control standards, as well as the new introduction of the antimicrobial stewardship programs to reduce inappropriate antibiotic use and also reduce antimicrobial resistance. These will all be tied into the QAPI, or the quality programs, as well. So quickly, with respect to patient rights, the document does discuss the prohibition of discrimination by healthcare centers. It notes that the Affordable Care Act and the Health and Human Services Office for Civil Rights does prohibit discrimination based on age, race, color, national origin, and disability. The Affordable Care Act was the first federal civil rights law to prohibit discrimination based on sex, including gender identity, in covered health programs. So it basically adds all these prohibitions to hospital and critical access hospital conditions of participation. The thought being that discrimination, or even the fear of discrimination, does tend to create barriers to care and ultimately leads to adverse outcomes. Now, with respect to patient rights, I'm not really sure why licensed independent practitioners was included under the heading of patient rights, but that wasn't my choice, that was theirs. So they did basically change or change the term licensed independent practitioner to essentially licensed practitioner. And what this effectively did is basically allow for physician assistants and people that don't work independently, quote unquote, to make orders or to give orders and practice to the degree that is allowed by both the state and hospital policy in which they work. So the thought was that it would avoid at least potential burdens from at the federal level for hospitals with respect to workforce, etc., and allowing PAs to practice to the full extent of their credentialing, and this would be up to the hospital and the state. In other words, it was taking the federal wording out of it that might be construed to prevent that. Now, with respect to medical records, essentially it liberalizes patient access to medical records, stating that an oral request is enough in addition to the traditional written requests. It does allow for the patient to request current medical records, not only past medical records. The form and format should be at the patient's discretion, whether it's electronic or hard copy. Records should be provided within 30 days or 60 days with an extension. And it does note that in facilities with electronic health records, they should be able to provide those in much faster than the 30-day time limit. Now, if patients feel that they are not receiving the records, they can file complaints with the Office for Civil Rights. So this document also does essentially updates the quality assessment component that was initially introduced in 2003. At that time, now 13 years ago, they did basically say that all hospitals have to have a quality component whose goal was to develop, implement, maintain, and evaluate its quality program. The program should reflect the complexity of the organization and services provided, i.e. the university academic quality program should be vastly different than that of a small community or a critical access hospital. It should be basically tailored to the needs of the facility and the services provided by that facility. It should cover and involve all hospital departments and services, and it should maintain evidence of what it does for CMS review. Now, that's the old stuff. The new stuff is basically that in the conditions of agreement, it will incorporate quality indicator data that is submitted to or received from other quality reporting and performance programs. In other words, it kind of codifies the fact that the quality program needs to report and receive information not only from programs within its hospital but also to reporting bodies or such as NHSN, etc. It encourages, but it does not require IT systems or IT technologies that are designed to improve patient safety and quality of care. Now, with respect to nursing services, it actually makes some changes that make it easier for most hospitals and facilities to work, in my mind anyway. It distinguishes staffing requirements between inpatient and outpatient settings. Earlier wording had said that an RN must be immediately available at the bedside for each patient, and this was interpreted to mean, or the question should it be interpreted to mean, should a nurse or an RN be physically present at all hospital facilities? And now that these guidelines are expanding to incorporate outpatient settings that are controlled by the hospital, they felt like they had to basically liberalize this requirement and allow the hospitals to establish and review their own policies and staffing requirements for each department. In other words, if in an MRI department, radiology department, taking routine x-rays, do you need an RN physically present? Probably not, but that's up to the facility. The federal government won't tell you what to do with respect to that. Likewise, nursing care plan details should reflect the complexity of the patient. Inpatients will have more detailed, ICU patients will have more detailed plans as opposed to outpatient settings. But there should be outpatient nursing care plans as well that are going to be relatively simple or straightforward. It also mandates that all licensed nurses who work at a facility, whether they're employed or contract employees, should adhere to hospital policies and procedures. Now, with respect to medical records, it basically extends the need for documentation from the outpatient setting, from the inpatient setting to the outpatient setting, again reflecting the services provided to the patient. It includes documentation of hospital-acquired conditions, infections, adverse events, whether it be to, say, a fall, for example, or adverse reaction to drugs or anesthesia. All these should be included in the medical record. Most importantly, it codifies the need for discharge and transfer summaries that basically outline outcomes, disposition, follow-up care plans, both for inpatient and for outpatient visits. It mandates the record should be completed within 30 days for inpatient visits and within 7 days for outpatient visits. So now we move to the meat of the discussion, as it were, and we'll talk a bit about infection prevention and control along with antibiotic stewardship programs and the guidelines that have been suggested for those. Now, with respect to background, infection control, we all know the term. It's been around since 1986, which I guess that's probably 30 years ago, isn't it? It's been around for a long time, and its the initial mandate was for infection control to identify, prevent, protect, control, investigate, and report infections. In 2012, they removed the redundant requirement because most people were reporting infections to various bodies, largely electronically, typically. They removed the requirement to keep infection control laws. And in that same year, they basically renamed quality assurance programs to QAPI, or Quality Assurance and Program Improvement programs. Now, Health and Human Services, basically with this document, has concerns regarding hospital-acquired infection-related morbidity and mortality. And the new guideline, or the updated guideline, is an attempt to address those concerns. In 2011, it was estimated that there were over 700,000 hospital-associated infections with 75,000 associated deaths. There's the growing threat of multi-drug resistant organisms and associated mortality associated with those organisms, and along with increased length of stay and cost associated with infections with those organisms. Now, the stewardship component was added primarily to improve prescribing practices, both in order to reduce the risk of C. diff, but also reduce the risk of other and future multi-drug resistant infections. It seems like we get a new resistance mechanism about every 6 months coming from somewhere to the United States. Overall, the goal is also to create a patient-centered culture of safety, where we don't have separate stewardship and infection control and QAPI programs kind of working independently, but they all work together, and along with the medical staff and the hospital staff, to encourage this culture and extend it to the patients and their families as well. So the term prevention was added to infection control to promote these larger cultural changes in all hospitals. Stewardship, the goal is to emphasize the hospital's role in fighting resistance through a program that follows guidelines, and they're actually quite liberal in terms of allowing for the hospital or the hospital system to choose which nationally recognized guidelines they choose to adopt or follow. Now, the term surveillance was also added in here, and it's kind of peppered throughout the document. Its goal is to basically detect infections, collect data and analyze that data, monitor and evaluate preventative interventions that are made, but also to document, to give documentation of activities that the hospital is using for surveillance, so that various bodies such as the Joint Commission and CMS can review those. And again, they basically state that the surveillance needs to follow guidelines, but they don't really mandate that any one set of guidelines needs to be followed. So the goal of surveillance, or the goals, I should say, include early identification of multi-drug resistant organisms, prevention of transmission of multi-drug resistant organisms, but also when ongoing transmission is identified, the goal of surveillance is to seek and remedy breaches or potential breaks in infection control practice so that transmission can be stopped and stopped in the future. So it's suggested that you can use automated surveillance, i.e. using IT devices to either to monitor resistance by either data mining is one suggested method versus query-based data management. Data mining is where you just broadly survey data and look for patterns as opposed to query-based management. Now, there are a variety of systems that exist out there, such as Vigilance and Theradoc, etc., and these can be purchased commercially, but also some hospitals have developed and their own systems that they can use. At a minimum, it's suggested that these automated surveillance systems should integrate parts of the medical record with laboratory, admission, discharge, transfer, and treatment information to make essentially a data package for each patient that can be analyzed in aggregate. So with respect to stewardship, the expectation is that a stewardship program should adhere to nationally recognized infection prevention and control guidelines. Again, CDC, IDSA, SHE all have their guidelines, or other bodies as well, that are acceptable and can be kind of used even piecemeal. You don't have to use one. You can use components of multiples. And it does allow for innovations or for changes over time in response to innovations in medical practice that occur with the overall goal of reducing harm. And again, it should reflect the scope and complexity of the services provided, varying from an academic center to a critical access hospital that doesn't provide surgery or does provide surgery. The program should be tailored to the needs of that facility. Now we'll focus a bit on the infection preventionist, or the former infection control officer. The infection preventionist, or the ICP, I love these acronyms, should be a person whose primary training is in nursing, medical technology, microbiology, or epidemiology. They then undergo, or they have undergone, education, training, or sometimes just experience or certification in infection control. And they're liberal with what that additional education needs to be. They should, though, participate and have funding to participate in ongoing education and training courses and meetings, such as those with APIC and SHE. Interestingly, they suggest that they should be appointed specifically by the medical and nursing staff leadership. Once again, so that the leadership of the hospital is invested in who that person is and how good they are and their ongoing function and career development. They do state that multiple IPs, if it's a larger facility, you can, let's say if you have 1.5 or 2 FTE or positions that are needed to cover a large facility, you can divide that up and you can have multiple IPs that work together as a team. The focus for an IP team or an IP provider is on the transmission of infection. But this has also been expanded, and I think this is a great idea, actually, and sorely needed, to not only include the entire hospital setting, including patients and visitors, but also it should be expanded to look at between facilities. And we've been working in Denver on a cooperative group that, for example, is trying to track and limit the spread of C. diff between hospitals and nursing facilities as well. And that is being encouraged in multiple venues, really depending upon what the needs of the community are. So again, C. diff infection, for example, is not only an inpatient disease, it's an outpatient disease. It's growing in the outpatient setting. And we need to understand and change our practices in order to accommodate this changing dynamic of C. diff and other multi-drug resistant infections. And there are some guidelines here that, regarding outpatient facilities as well that were recently released by the CDC. So with respect to stewardship programs, and the background and the need for those programs, it's been long known, at least over the course of the past probably 10 to 20 years, that antibiotics have been given, or commonly given, without proper evaluation. Antibiotics are often given for too long or when they're not needed at all. There are variable prescribing habits between facilities. Patients in some facilities receiving the same level of care could receive 3 times the amount or the number of antibiotics as another given facility without any real change in outcome with respect to their initial infection. It's also been shown that a 30% reduction in the use of broad-spectrum antibiotic use can lead to a quarter reduction or 26% reduction in the prevalence of C. diff infection. So there really is a need to better control and reduce our use of antibiotics for multiple reasons. And so the IDSA and Shea came out with a definition of stewardship program and what it should do, and it should basically encourage the optimal use of antibiotics to achieve the best clinical outcomes while minimizing adverse events and limiting factors that lead to resistance, excessive cost, and suboptimal use of antimicrobials. So the goals of the program are really to coordinate all the components that are responsible for antibiotic use and the factors that lead to the development of resistance. And these components, as I mentioned earlier, it's not just the stewardship committee working alone. They need to work with infection prevention, the quality committee, and with the medical nursing staffing, and the pharmacy is a critical component of that. They need to be able to document that they do have protocols for the evidence-based use of antibiotics, and hopefully those protocols are actually being used. They need to demonstrate improvements in proper antibiotic use over time. And hopefully you will be able to see outcome improvements, not only process-related improvements, but outcome improvements with respect to the incidence of C. diff infection, antimicrobial resistance, etc. And the program should reflect the scope and complexity of the hospital once again. So it's important for leadership to be engaged in this process. They give examples of hospital leadership, CEOs, the C-suite, so to speak, participating in executive walk-arounds, increasing staff awareness and communication, and they stress the need for non-putative reporting as well. That would tend to discourage the reporting of problems. Again, the hospital leadership should work with these other bodies in a coordinated fashion. I'm going to move a bit quickly through this as we're kind of running a bit short on time. But the infection prevention responsibilities, essentially the goals are to communicate with quality committee, document surveillance, prevention and control activities, the education of medical and hospital staff, and collaborate again with the stewardship program. There should be a stewardship leader. This is a person, typically a physician. It's been shown to work best in most hospitals, who's basically has the responsibility of developing and implementing the program, documenting the stewardship activities, and communicating with the other groups. Also, education and the medical and hospital staff is the responsibility of that person. Not that he or she has to do it himself, but they need to make sure that education is happening. Now, with respect to critical access hospitals, it seems like there's a lot of stuff here, a lot of process that may be difficult for smaller hospitals to rapidly adopt and implement. But I think what is noted in the body of the guideline is that there has been significant variation in antibiotic prescribing between hospitals, and actually what they've seen is that the lower the severity of illness and the smaller the hospital, there tends to be more antibiotics given per patient at a greater cost. And there are multiple factors that could be associated with this higher antibiotic use, but it is a particular area of concern, and the guideline is trying to address that and trying to make changes in basically implement these infection prevention and stewardship programs in these smaller hospitals to help them improve from a quality standpoint. So the requirements regarding all of these components I've discussed are the same for critical access hospitals as they are for larger hospitals. Having said that, as I've mentioned a couple of times, these programs need to be tailored for the needs of that hospital and the scope of practice of that hospital. Now, public comment closed for this document on, I guess, just last week, on the 15th. And we can discuss the feasibility of implementation. But I know that the SHE had solicited comments from critical access hospitals specifically to try to offer critique and comment on the guidelines and the feasibility of the guidelines for the smaller facilities. Now, I'm not really sure when the CMS will go through this process and actually implement these changes, but I do know that the Joint Commission requirements will be effective as of January 1st of next year. And essentially what the Joint Commission requirements do is essentially mirrors what the CMS document states with respect to leadership involvement, making stewardship a priority with respect to budget plans, infection prevention, etc. Education of staff regarding antimicrobial ordering, dispensing, and stewardship practices. This should be done upon hire and periodically after hire or granting of privileges. The education of patients and families. It extends to not only to staff but also to families, and basically giving them some information about why we're trying to appropriately use antibiotics and why not everybody needs antibiotics. And there's some documents that the CDC have published toward this end. Some are better than others. I'm not really that excited about their the quality of what they put out so far. But again, stewardship, the multidisciplinary team is important, and the core elements are essentially the same, combining leadership commitment with a single physician leader, drug expertise, actions taken or implemented, such as the 48-hour timeout with broad-spectrum antibiotics, tracking and education all kind of remains within this guideline as well. The use of organization-approved protocols, such as those for formulary restrictions for certain antibiotics, community-acquired pneumonia, skin and soft tissue infection, UTI guidelines, things that we've been working on here at CHA, are encouraged. And again, the hospital needs to collect, analyze, and report data to both CMS and the Joint Commission. The hospital is also tasked with taking action on identifying opportunities for improvement and taking action on those opportunities as they deem fit. So there's a lot to digest here, and I know that we're running short on time, or maybe we're actually close to being out of time. For those that have time to hang on for a few minutes, myself and Terry would be happy to field any questions or concerns or ways going forward as these plans kind of roll out of the pipeline, as it were.
All the lines should be open, so if you have a question, feel free to chime in, or you can type it in the chat box. Go ahead and see if anybody's typed anything in. Any questions?
Will the slides,
sorry, go ahead.
Slides be made available?
Yes, so the slides will be made available on the box.com site as usual. We may have another option coming out for you that will we will communicate with you shortly. The recording will also be available on box.com.
Thank you.
Yeah, you're welcome.
This is Carrie, and I typed in a question, but I'm not sure if it went across.
No, I don't see it.
I was just wondering, with the resistance of the fluoroquinolones, are community-acquired pneumonia orders still say Herceptin and Zithromax or Levaquin? Are we not supposed to be using Levaquin for community-acquired pneumonia now?
So that's a great question. The resistance, well, first of all, let me state that the community-acquired pneumonia guidelines are in revision right now, and hopefully, or I'm told they'll be coming out this fall, basically on the heels of the hospital-acquired pneumonia guidelines and ventilator-associated guidelines. Having said that, the resistance that we see to Levaquin, fortunately, is only in the gram-negative realm, and Levaquin and the other respiratory fluoroquinolones are still very active against pneumococcus, which is the primary target, and atypicals, which are the primary targets of that drug. So my guess is that the Levaquin will remain in the guidelines. We may, in the setting of emerging gram-negative resistance, with increased use of Levaquin, we may see them somewhat de-emphasized in the protocol, but my guess is that they still will be in the CAP guidelines.
Okay, thank you.
Sure.
Any other questions or topics for discussion?
This was a good overview.
Well, thanks. It was kind of a daunting topic. I thought it would be pretty straightforward when I jumped into it, when I signed up for it, but there's a lot of information, and hopefully it was I was able to summarize it fairly well. I think that overall, but I do have I have some question, and I'd like to solicit feedback as to whether smaller hospitals. Do you think that you'll have the capability with current levels of staffing and availability of the physician and infection preventionists to provide this level of care, or do you think there might be issues going forward with the potential need for that? There was a mention in the Joint Commission guidelines, and I think I put in the slides but didn't talk about, that telehealth was left open as an option, as well as part-time hiring of infection preventionists as well. So that's something. I'd be happy to see if anybody out there thinks that there might be a need for that going forward, but also the feasibility of that.
This is Carrie, and I'm from a critical access hospital. We were using Script Advisor until they, stopped. I think just being able to talk to infectious disease is very helpful, because we do tend to use sometimes 2 or 3 antibiotics. We were fitting into that category. So.
Yeah, I was aware of Script Advisor and actually was slated to start maybe working with them next spring before it all collapsed. But I think that would be one component or one model. What I'd like to think about now in the setting of these new guidelines is whether certainly we can have somebody available to talk to about specific cases, but also whether we would need to have, or what the need out there might be for a more kind of formalized programmatic consultation, whether that be a one-time to set things up or an ongoing need for a small group of maybe somebody who works in stewardship, IP, maybe information technology, to help any facility in the state to kind of get up and running with these guidelines, and perhaps provide ongoing staffing if that's needed as well, or ongoing surveillance and review of documentation, etc.
Would be helpful.
So I think it might be interesting to see if the CHA might be able to pull the critical access hospitals to see if there may be a need for that. And because I think obviously it's in CHA's interest for its member hospitals to be able to be up to speed for that. Whether CHA would be able to provide that service or not, I'm not sure. My guess is that I don't know if it's within their realm, but I don't understand that business model. But we can certainly maybe look at least get a needs assessment and so we can look at options for various facilities of different sizes, to be honest with you.
Mm-hmm. Any other comments or questions?
This is Mark. Can you hear me?
Yes, we can hear you.
Hey, so Terry, on John, I think there is money coming from the CDC, but it's coming to from what we're told from Arjun Srinivasan, it's coming to the local
Health departments.
State health departments. And so how they handle that money, I'm hoping in the next collaborative meeting we can discuss with Wendy how that money is going to be utilized in Colorado, specifically for some of these critical access areas that don't have their own network of ID support. Also, I'll put a plug in. Terry and I are working on a paper with some people around the country that should come out after October, I believe, Terry. Is that right?
Yeah, I believe so.
And then it's going to be on problems associated with stewardship in small hospitals, critical access hospitals, and offering some insight into how you can accomplish these goals and offer some advice is the plan for that. So I'd be looking for that coming out hopefully before first year, and we might get some answers to how we can get some money for ID support in these underserved areas.
Great, thank you, Mark.
Yeah, that'll be very helpful, and certainly, we'll definitely make sure Wendy's at the next meeting so we can discuss their plans for these monies. I look forward to seeing that paper. Maybe Terry can forward me a draft.
It's supposed to be a clinical infectious disease, but we don't know for sure when it'll be published. But it's not written yet.
We're working on it.
That's a good first
We're
step.
working on it.
Excellent.
Any other questions? I know that we've gone over, and we appreciate you guys for hanging on, but we want to make sure we get all your questions answered. Is there any lingering ones out there before we let you guys go? All right. If you guys think of anything, feel free to email us here at CHA, and we will make sure to get you an answer promptly. And we hope you guys have a fantastic day. Again, this recording and the presentation will be available. And if you guys have any questions, just let us know.
Thanks, everyone.
Thanks, guys.
Thanks.